Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach for Step 1 and Step 2. Today we'll be reviewing a Step 2 CK question in cardiology. So I would like you to try to work through this question on your own first before we approach it together. So pay attention as we read the STEM because we will have to advance to a different slide in order to answer the question on your own first before we work through it. So, a 42-year-old woman presents to the emergency department with sudden onset of palpitations. She has a history of anxiety and panic attacks, hypertension, and hypothyroidism. Her medications include sertraline, buspirone, lisinopril, and levothyroxine. She typically eats a varied diet, but her oral intake has been limited as she recently completed a course of antibiotics for a community-acquired pneumonia. She drinks 2 to 3 cups of coffee daily and occasionally uses recreational drugs. She is afebrile, heart rate is 170, respiratory rate is 18, and blood pressure is 142/84. She appears very anxious and is mildly diaphoretic. She's alert and oriented to person, place, and time. Pupils are 3 millimeters, equal, round, and reactive to light. Extremities are warm and well perfused, and radial pulses are 2 plus bilaterally. The remainder of the examination is unremarkable. EKG is performed and is shown here. So we see the EKG here. What is the most likely cause of these findings? So I'd like you to pause the video for a moment and try to pick the best answer on your own first. All right, so welcome back. So let's work through this question together. As always, the first step is going to be to look at the very last sentence to read the question itself to see what the question is asking us. So what is the most likely cause of this findings? So this is going to be a question about the underlying etiology. So we're going to be looking for a cause or etiology. And then we glance at the answer choices very quickly, no more than a few seconds here. And we see that some include electrolyte abnormalities, some medications here, some physiologic states like dehydration, some substances. So a pretty wide variety of answer choices. So that's helpful in framing what we're thinking about as we're reading the STEM because we're going to think really broadly about this patient. We're not just looking at medications, but we're looking at other things as well. So we're going to keep an open mind when we approach the question STEM. So let's start from the top. A 42-year-old woman presents to the emergency department with sudden onset of palpitations. She has a history of anxiety and panic attacks, hypertension, and hypothyroidism. Her medications include sertraline, buspirone, lisinopril, and levothyroxine. So really important when we're reading a question stem to pay very close attention to the comorbidities and the medications. Oftentimes, these could be there as distractors, but they could also be really valuable information. And sometimes there's going to be a question about an interaction with medications or a side effect of the medication or something related to the medication or even something about the patient not taking their medication, so you have to pay attention to whether they mention anything about adherence. And the comorbidities are also really important because often certain things will be associated with certain comorbidities, so you have to pay attention to that. So don't just skim through it quickly. Definitely pay attention to it and highlight those comorbidities and medications. She typically eats a varied diet, but her oral intake has been limited as she recently completed a course of antibiotics for community-acquired pneumonia. She drinks 2 to 3 cups of coffee daily and occasionally uses recreational drugs. She's afebrile, heart rate is 170, respiratory rate is 18, and blood pressure is 142/84. So blood pressure up at the upper end of normal. She has a history of hypertension. She's a little tachycardic, so that's not out of the realm of normal for this type of presentation, but definitely something to keep in mind. And the heart rate is definitely elevated, so she's tachycardic. She appears very anxious, is mildly diaphoretic. She's alert and oriented to person, place, and time. Pupils are 3 millimeters, equal, round, and reactive to light. So often these long stems will have a number of physical exam findings that are actually completely normal, but they're there to make you question or doubt yourself. What's a normal pupil again? Is it 2 millimeters? Is it 4 millimeters? Is it 5 millimeters? So the range of normal is 2 to 4. So you do want to have a good sense of like pupils, for example, how big they normally are. Liver span below the costal margin. What is a normal number of centimeters? So those types of things, because often they won't tell you there was no hepatosplenomegaly. They might just tell you that the liver span was palpable 1 centimeter below the right costal margin. So you have to know whether or not that's a normal finding. So definitely pay attention to these findings, and just because they tell you the actual number itself doesn't mean it's abnormal. Extremities are warm and well perfused, and radial pulses are 2 plus bilaterally. Same with pulses, same with reflexes, all these numbers they give you, you should know what the normal range is. The remainder of the examination is unremarkable. EKG is performed and is shown here. So overall, this exam is pretty unremarkable besides the tachycardia and the general appearance of the patient, but everything else is within normal limits. So then we move on and we look at our EKG. So let's review a few steps about how to approach an EKG. First of all, for the board's questions, you don't need to know how to interpret every single random EKG that you might see in the wards or in clinic. There's only a very limited number of rhythms that you need to be able to interpret and recognize. So if you get practice identifying these rhythms, there's maybe just a handful that will actually show up on your exam. It won't be a random EKG that you've never seen before. So that should be reassuring. When we are approaching an EKG, a few basic steps to always do to help us identify what the rhythm is. So first we want to look at the rate. And the quick trick for this is to identify two QRS complexes that fall on the solid line. So we see those, for example, here. You look at the number of big squares in between these two QRS complexes, and you divide 300 by the number of squares. So here it's just about 1. It's not perfect with every QRS interval, but pretty much it's about 1. And this is again a ballpark, it doesn't need to be perfect. So let's say the rate is approximately 300 divided by 1, or maybe 1 to 1.25. So big picture, it's going to be about 275 beats per minute. And again, this is supposed to be an approximation. It doesn't really matter whether it's 270 or 280. That's not going to change how we approach the EKG. It's fast. That's what we need to know. And it's very fast. So the rate, then we take a look and we look at the rhythm. So when we look at the rhythm, we want to see, is it regular? Or is it something irregular like atrial fibrillation? We also want to see if it's sinus rhythm. So is there a P wave before every QRS? And in this case, we're not really seeing any P waves. We're just seeing QRS complexes. And it looks pretty regular. When we're talking about whether it's regular, really the most important thing here is to rule out atrial fibrillation, where it's going to be very obviously irregular. So here we're not in sinus rhythm because we don't see a P wave before every QRS. And then the last thing we're going to look at is we're going to look at the intervals. And here we don't have P waves, so we can't really see the PR interval, but we can look at the QRS interval. And we're looking and seeing if it's narrow or wide because we're in a tachycardia. And here it looks wide. And remember that wide is greater than 3 little boxes or 120 milliseconds. And again, you can pretty much eyeball this. You don't need to sit there calculating every single QRS interval. You can just take a look at 1 or 2 of them, and it very obviously looks wide here. And then when we're talking about a wide complex tachycardia, it's important to then look and see, is it monomorphic? Is it polymorphic? Are there any other findings associated with the strip? And so what we're seeing here is that these QRSs look very different from one another. So this would be described as a polymorphic. They don't have the same shape. And one of the important features is that the shape kind of differs in terms of height. And so when we take a look at it a step back, we see that it has this sinusoidal pattern right here. And that sinusoidal pattern is very characteristic of torsade de pointe. Now, for other EKGs, depending on the clinical scenario, you might be looking for ST elevations, you might be looking for a Wolff-Parkinson-White pattern, you might be looking for the axis if it's specifically a question about axis, or maybe bundle branch block, but you'll be able to identify pretty quickly beyond just these basic things, rate, rhythm, intervals, if there's anything else special that you're supposed to be looking for. Now, if these are all normal or you're not exactly sure what's going on after this, certainly you can look for some of these other features. But again, like I said, there's a limited number of rhythms that you will need to identify on the board exams. And so once you get familiar with those, it'll be pretty obvious right away what rhythm you're dealing with. So here, we're dealing with a sinusoidal, wide complex, polymorphic tachycardia. So this is consistent with torsade de pointe. So Let's take a look at the question. So now the question is asking us, what is the most likely cause of these findings? So remember, boards questions are often two-step questions. The first step is to identify the underlying diagnosis, and the next step is to answer a question about it. So here we identify that this was torsade de pointe. And now the next question is understanding what is actually causing this. And looking at these answer choices, we have a lot of different things here. So these questions can be very overwhelming, the ones that have 8 or 12 answer choices. So it's really helpful to have an idea of what we're looking for before we take a look at these answer choices so we don't get distracted. So this is an additional step that I recommend taking between reading the stem and actually going to the answer choices is to put together, to synthesize the elements from the history to identify the diagnosis, which we've done here, right? This is just based on the EKG, we can identify what the diagnosis is here. And then to have an idea of what we're looking for in the answer choices. So try to come up with one or two answers on your own about what might be the underlying cause in this patient, and then go to the answer choices and see if what you came up with matches what's there. That'll help you avoid getting distracted by some other answer choices that might sound correct if you've already, forgotten what you read in the question stem. So this step should only take you 10 to 15 seconds, but is really crucial in not getting distracted. So in our question stem, we had a lot of potential risk factors or etiologies, right? We had a lot of past medical history, we had a lot of medications, we had some substance use. So there's a lot of different things that could be going on here. So if you understand what the causes of torsade de pointe are, this is going to be a very classic high yield step question that is frequently tested that you'll be able to identify right away. So let's move forward and learn a little bit about torsade de pointe and then take a look at the answer choices again. So the major risk factor you may remember for torsade de pointe is going to be QT prolongation, okay? So when that QT gets prolonged, it's a setup for torsade de pointe. This is going to present like any other arrhythmia, especially any other um, tachycardic arrhythmia with palpitations, dyspnea, maybe some chest discomfort or chest pain, maybe syncope or presyncope, or even more seriously, this could progress into VFib and death. So the major complication and risk here is that this rhythm can rapidly degenerate into VFib and sudden cardiac death. Okay, so this is not something to just twiddle our thumbs about. This is a very serious rhythm when we see it. The EKG features are going to be, like we mentioned already, tachycardia, and typically the heart rate's between 160 and 250, although I wouldn't hang your hat if it's 275, that could still be very consistent with this. And classically, the presentation will be these shifting sinusoidal waveforms. So whenever you see that pattern, kind of the sinusoidal pattern of the rhythm, you should already be thinking about torsade. This is very classic. Um, and it's also sometimes described as a polymorphic ventricular tachycardia. So don't be tricked if you're looking for torsade and you don't see that, but you do see polymorphic ventricular tachycardia. That is still an appropriate description. So I'm going to add that here, right? Because it's still a ventricular rhythm, it's still a tachycardia, but the difference with regular VTach, which is monomorphic, is that here we have a polymorphic rhythm. So these are synonymous, torsade de pointe and polymorphic VTach, for the purposes of the board's exams. In terms of management, as with all arrhythmias, it's going to essentially depend on the stability of the patient. So if the patient is stable, you may remember that we don't use an antiarrhythmic here, but we actually use magnesium. Even if the patient's magnesium levels are normal, don't get fooled. They may give you this to try to trick you. Regardless of the patient's magnesium levels, magnesium is still the right answer if the patient is stable. Now, if the patient is unstable, as we mentioned, there's a high risk of this patient degenerating into VFib and even potentially sudden cardiac death. So this is one of the arrhythmias where we go straight to defibrillation, or also called unsynchronized cardioversion. And remember that the signs of instability for arrhythmias and ACLS algorithms is going to be hypotension, altered mentation, respiratory distress, or ischemic chest pain. So if you see any of these features, you should not wait and you should immediately defibrillate this patient because they're at risk of degenerating into VFib and sudden cardiac death. Now, we still haven't really talked about the causes. So the causes are really going to all hinge on causes for QT prolongation. So this question was actually more of a combination of physiology and pharmacology question, although you certainly did need to identify this rhythm correctly. So let's talk a bit more about QT prolongation. This is a very high yield topic for the board examinations. So there are some congenital causes of QT prolongation that include these very rare pediatric congenital syndromes, although in the boards they certainly will pop up here and there, called Jervell syndrome, Lang-Nielsen syndrome, or Romano-Ward syndrome. If you don't remember what those are, just pause the video for a moment and refresh your memory. We won't review it here. Other causes are going to be electrolyte abnormalities. So most commonly hypomagnesemia, hypocalcemia, and hypokalemia. So pay attention to electrolytes or potential electrolyte disturbances in questions about QT prolongation. And then finally, there's a whole number of drugs or medications that can induce QT prolongation. So the list is exhaustive, but you don't need to know every single medication for the purposes of the boards. But there's a nice mnemonic that can help you remember which medications are the most likely culprits, at least the ones that most often get tested. So it's A, B, C, D, E, F is the mnemonic. So A stands for antiarrhythmics, specifically class 1A and 3. If you don't remember which ones fall into that category, I do think it's helpful to at least know what the names are of the medications that fall into this category. The ones that are most commonly associated with QT prolongation are quinidine and sotalol, although amiodarone can too, and other antiarrhythmics in class 1A and 3 can too. So refresh your memory of these if you don't remember them. The B stands for antibiotics, and the most likely culprits are going to be fluoroquinolones as well as macrolides. Okay, this gets tested all the time. C stands for antipsychotics. It doesn't fit as well, but especially Haldol, other antipsychotics as well. But remember that Haldol has a lot of side effects, and this is the most likely culprit in the antipsychotic category. D stands for antidepressants, but be careful here. It's not all antidepressants. The most likely culprits are going to be TCAs. Sometimes SSRIs can as well, but most commonly tested is going to be TCAs, and highest risk is going to be TCAs. The E stands for antiemetics, and the very classic antiemetic associated with QT prolongation is Zofran or ondansetron. So this is also very highly tested. And then the F stands for antifungals like fluconazole. So for some reason, they love to ask questions about this because it takes you back all the way to pharmacology and to knowing all these little details about the side effects of medications. So I really like this mnemonic. I use this for all my boards exams, and I found it the easiest way to remember what the medications are that cause QT prolongation. So congenital causes, electrolyte disturbances, and drugs. So now that we've learned what the most likely causes of QT prolongation are, let's take a look at our answer choices again and work through this together. So hyperkalemia. Now, definitely you could have gotten tricked because you remembered that maybe vaguely electrolyte disturbances. That's correct, but it's actually hypokalemia, not hyperkalemia. So answer choice A is incorrect. A panic attack. Now, initially, we learned that this patient had a history of anxiety and panic attacks and was presenting with palpitations and some diaphoresis. This could certainly be consistent with a panic attack until we got this EKG, right? You would not expect any EKG abnormalities, any arrhythmias with panic attacks. So once we have a more likely organic or medical cause of the palpitations, panic attacks is no longer on the differential. So we can rule that one out. Dehydration. Dehydration, we learned that she had had perhaps poor oral intake the past few days because of her community-acquired pneumonia. Certainly, dehydration can be a setup for certain medical conditions, but in this case, we haven't really learned about dehydration being a risk factor for VTAC, or I'm sorry, for polymorphic VTAC, so we can cross that one off. Levothyroxine. So this is interesting because we know that hyperthyroidism is associated with arrhythmias. Now, a key learning point here is that too much thyroid, whether it's endogenous or exogenous, can actually be associated. The most common arrhythmia associated with too much thyroid is going to be AFib. So this also gets tested all the time. However, here the patient has a history of hypothyroidism and takes levothyroxine, but we don't have anything in the stem telling us that she's taking too much or more than she's prescribed. And when we look at the rhythm, it's not consistent with AFib. So this was here kind of as a red herring if you were maybe thinking that the levothyroxine could potentially be causing the palpitations. It would be possible in a question with a rhythm consistent with AFib, but here there's too much pointing us towards a different etiology. So this is incorrect. Caffeine, again, a stimulant. Stimulants can cause tachycardia, but these stimulants are not known to cause torsade de pointe. So caffeine and cocaine as well, we're told that she uses recreational drugs occasionally. So that's always great to think when we're thinking palpitations and recreational drug use, to think of stimulants, methamphetamines, cocaine, etc. But in this case, even though we're not specifically told which substances she uses, we have another more likely explanation. And we don't know about caffeine or cocaine being specifically associated with torsade de pointe. Maybe it's associated with palpitations, but nothing specifically is associated, no substances specifically associated with torsade de pointe, and we have another more likely explanation. So we can cross these off. Buspirone. So psych meds in general are great to think about QT prolongation, although Haldol is the more likely culprit, as well as maybe SSRIs, but buspirone doesn't fall into either of those categories. So I think although it's really important to remember psych meds as being associated with EKG changes, in this case, buspirone doesn't have any associated EKG changes as one of its side effects. So we can cross that one off. Lastly, amoxicillin and azithromycin. Now, this is tough because you remember that maybe the B in A, B, C, D, E, F is the B stands for antibiotics, but you have to know specifically which antibiotics. And so in this case, we know that macrolides and fluoroquinolones are the two classes of antibiotics that are associated with QT prolongation. Amoxicillin and penicillins are not. So although this sounds like this is here to trick you, right? They both start with an A, they're both antibiotics, but you really have to pay close attention. Azithromycin is a macrolide and is the most likely culprit here, whereas amoxicillin is not one of the antibiotics that is associated with QT prolongation. So remember, macrolides and fluoroquinolones are your antibiotic classes that are associated with QT prolongation. So we can cross H out, and the correct answer is I, azithromycin. All right, so that wraps up our question of the week, and thanks so much for listening.